Everyone. Welcome to In Limbo Conversations. Today we have with us Meredith Schwartz. She's an assistant professor of philosophy at Ryerson University. Her university focuses on the moral concepts of respect, responsibility, trust, and risk as they are deployed in clinical ethics and health policy. For more information about her work, please check the links mentioned in the video description. Thank you for joining me, Meredith.
Thank you for having me.
Yeah, so
Pleasure.
Thank you. In today's conversation, I'd like to focus on some of the points you have raised in your book, Moral Respect, Objectification, and Healthcare. In the book, you presented an egalitarian account of moral respect, which applies to both non autonomous and autonomous patients. And more importantly, given the current pandemic situation, you also talked about why moral respect is central in medical context. So, I thought we could start by talking about the current pandemic situation and the objectification that usually occurs within medical situations. You have discussed how modern medicine is inherently objectifying and also mentioned 10 forms of objectification which occurs. So I was wondering if you could tell us why you find modern medicine to be inherently objectifying, and maybe you can give us some pandemic specific instances if you feel up to it, of where you have seen these forms of objectification occur.
Sure. So in the book, my goal was to put forward an egalitarian account of respect, because the more traditional account of respect in bioethics, which is respect for autonomy, where autonomy is understood as medical decision making, it leaves out a whole lot of people, because many people aren't autonomous, maybe because they're too young, they're children, maybe because the very illness that they are seeking treatment for might render their autonomy skills, might lower their autonomy skills, or perhaps even get rid of most of their autonomy skills. So I thought it was really important to have an account of respect that applies to everyone, because as I understand it, respect is the moral concept in Western philosophy that recognizes equal moral value. And I think that when we respect someone, we treat them as a being that has inherent value. And although it does make sense to have a certain amount of capacity to have someone respect your decisions, because if you lack that capacity, then the decisions that you make might not be wise, because you might not understand entirely what you're doing. But it doesn't seem like you need to have autonomous capacities to deserve respect as a person. So in the book, I talk about the Kantian idea that respect is the way that we engage with someone when we engage with them as more than a mere object. And so I take his account of dignity, which he describes as a certain kind of value. And I say that respect is founded on dignity. It's founded on that kind of value. And I see the value of dignity as being a kind of intrinsic, absolute, inalienable value that differs from price. So price is what you can gain on the marketplace. And when we think about treating someone as more than a mere object, we'll find that denying their autonomy or violating their autonomy, that is recognizing that they have autonomy and ignoring it anyway, both of those are hugely important ways of objectifying someone. And so I'm not at all criticizing the idea that we ought to respect autonomy, but I'm saying that there are other ways of objectifying people too. So for example, you can treat their subjectivity as though it doesn't exist or is unimportant, where I understand subjectivity to be more of one's emotional reactions, one's experience of the situation, not necessarily one's decision-making capacities. Or you can treat people as fungible. So something is fungible when you can exchange two things of the same kind for one another without loss of value. So for example, if we traded $1 for another dollar, you don't care that you have this particular bill because it has the same value, so it's fungible. Or if you have one cord of wood, you can change it for another cord of wood of the same grade without loss of value. But people aren't like that. So I can't just take your mother and kill her and then give you another mother and say, oh, that's fine, because that would entail a loss of value. So Another way of objectifying people is to treat them as fungible. You can also treat them as inert, that is, as lacking agency. You can reduce them to nothing but their body. There are a whole variety of ways that I describe in the book. There's 10, and they're inspired by Martha Nussbaum, Ray Langton, and Kay Toombs's work on objectification. Now, their work is done in a sexual context mainly. So they're thinking about sexual objectification of women. But what I wanted to point out in the book is that medicine is also very objectifying, because medicine treats the object body. So it's looking at physiological processes, and it's trying to fix those physiological processes. So, the medical method has to treat patients as fungible to a certain extent. So if this patient couldn't be compared or sort of made equivalent to previous patients, then we'd have no idea how to treat them. It would be new every time. So we do have to sort of think about one person in terms of their exchangeability with another. Sometimes in medicine, it's appropriate to treat people as inert. So for example, if the patient is in a coma or if the patient is undergoing surgery, then you have to treat them as inert. And in fact, treating them as inert might actually be a way of respecting them, since that's what you have to do to keep them alive under those situations. Medicine also has a focus on the body. So it's not necessarily going to reduce the patient to the body. It might try to treat the whole patient. But in terms of curing the illness or treating the illness, it's going to be focused on the object body rather than other things. And so for all these reasons, I think that people can experience the medical encounter as incredibly objectifying. And this isn't always going to be the case. So if you just go in to get a flu shot, you're just in and out, and it's perhaps not that important in that kind of a context. But particularly if people are dealing with chronic issues or issues that are serious and going to affect their life plans, or if people are in an institutionalized setting, then I think a focus on trying to counter the objectification with a respectful engagement becomes more important, particularly in institutionalized settings, because the setting itself removes a lot of those things that make up a self, right? So in an institutionalized setting, the room that you're in might have a few of your objects, but not to the same extent as your apartment or your house. And so a lot of those things that would hold your memory and yourself aren't present. So in those settings, it's particularly acute.
So in contrast to this objective attitude, you mentioned an interactive attitude, sort of, which attends to the patient's uniqueness, their non-fungibility, and their inherent moral value or dignity. So is this attitude also related to the communicative view of respect, which you have explored in your dissertation, which was titled Respect and Healthcare Ethics, Respect, Social Power and Health Policy? Could you tell me a bit more about the interactive or communicative attitude and about second-person respect in medical contexts?
Sure. So the idea of respect as involving a second person relation comes from Stephen Darwall's work, and he's drawing on Strawson's work. And so the idea is that we can interact with people from different perspectives. So these perspectives follow the grammatical persons. So we can take a first person perspective on a moral issue, for example, when we're asking about our own self, reflecting on our own self. So how should I live? What should I want? What should I do now in light of my other values? What kind of person should I be? The sort of virtue ethics questions. And so that's one way we can reflect. Probably the most common way that philosophers have thought about moral issues is from the third person. So the third person is when we take the perspective of an outside judge who is impartial and is reflecting on the situation with a view from nowhere, perhaps, to use Nagel's term. And this has been attractive to philosophers because it's seen as a way of being unbiased, of in investigating a moral situation in an impartial and unbiased and disinterested way. But as Carla Bagnoli points out, you can engage with another person without necessarily taking up a bias. And so the second person standpoint is where we recognize the moral equality of the other. And Darwall's work really focuses on reactive attitudes. So he's looking at attitudes like praise and blame, where we see each other as having equal moral authority, and we see each other as the source of reasons. And so, for example, if you tell me to get off your foot, it's because you're telling me to get off my foot that I have that obligation. It's not just an impartial obligation. So I took that idea from Darwall, but I think that his account is too limited because on his account, he really focuses on reactive attitudes and equal moral authority. And so that means that his account, like other accounts that focus on autonomy, are going to exclude those who lack authority, perhaps because of an illness that they're experiencing, or perhaps because they're too young. When he talks about children in his book, he says you can't really respect them, you can only show them quasi-respect. And so what I wanted to do is sort of have a fuller accounting of the moral domain, where we might treat each other as an equally morally valuable person. And so I think there are other activities besides reactive attitudes where we show a person's value. For example, caregiving. When we give care to another, then we do so as an expression of our recognition of their value. When we hold each other in personhood, to use Hilda Lindemann Nelson's words, then we're showing that that person has value to us. So for example, you might have a parent who has Alzheimer's disease, but you still have those relationships and those relational connections, and you still tell stories and engage with them emotionally. Although this can also be difficult as their capacities change, it's part of the way that we show that the person still has equal moral value despite limited capabilities.
Yeah. Okay, so I was wondering, are there any instances you have seen during the pandemic which have sort of stood out for you as objectifying or interactive? Like, is there anything that you see as objectifying during this context or interactive?
Sure. In the book, Moral Respect, Objectification in Healthcare, I had a section where I talked about long-term care homes and some of the problems that I see there. And I think that we saw that play out very much in the context of the pandemic. At least in Canada, we had some horrible atrocities arise. For example, there was a long-term care home where many of the workers just abandoned their work. They just didn't come in. They didn't have adequate personal protective equipment or PPE. And so they just left the residence. And when people came back, they found people lying in their own excrement. They found people who had died and not been properly interned. And so in Canada, we had to bring in the army to help with that situation. And I think that situation, it actually reflects a lot what I was talking about in chapter 4, where in Ontario, not every care home, different care homes use different models of care, but many care homes are using a sort of task-oriented model of care. So that's where the personal support worker is charged with doing certain things like feeding and bathing and clothing. And they have to report on this to their managers. And they're not given very much time. So they're only given the bare minimum of time to do it. And so that encourages a sort of objectification of the person. And this can be particularly true if the person has a non-normative way of being in the world. That is, if they have Alzheimer's and perhaps it's hard to interpret what they're saying or what they're doing as meaningful. And so this takes time. And so what happens, I think, in those kinds of situations is that without the meaning making, without the time to develop these second personal respectful relationships, there's going to be less tying you to the person. And in this situation, I want to say that it's not just objectification of the patient who's receiving the care, it's also a form of objectification of the healthcare worker. So the healthcare worker, the personal support worker, rather than being valued as a human being, is being treated like a cog in a machine, something that is just there to do a task. And so without the respect for the healthcare worker, it's hard for them to engage in making meaning. So Kantianism is often contrasted with utilitarianism, and I see something similar in this kind of a situation where the long-term care homes are trying to maximize the bottom line, and so they want to maximize efficiency, which is a utilitarian type of idea. And respect is saying, no, you can't do that. You have to also account for someone's humanity, for their meanness, and for our need to engage with each other as moral equals.
Right. Okay. In this context, in the book, you had also mentioned a limitation. So you had said that it is not a form of respect that can easily be adopted by a healthcare professional in the absence of institutional support. So what do you think are the concrete measures or practices which can be taken in the medical situation today, especially in the health crisis situation, to have an interactive and respectful attitude to the patient?
Okay, so let's just stick with the long-term care home example, and then I'll provide some more positive examples. So in the long-term care home example, I think one of the things that would help is to change decision-making structures. So Joan Toronto talks about care ethics, and in her discussion of care ethics, one of the things that she describes is these 4 phases of care. So first, we need to decide what needs exist, so that we have to care about something. Then we have to decide how to care for it. So how are we going to meet those needs? Then we have to have someone who gives care and someone who receives care. And Toronto points out that in hierarchical bureaucratic structures, the first 2 phases are often separated from the second 2. So it's often managers or board members who are deciding what the needs are and how to meet those needs. And so that's often happening from a sort of objective stance, right? So what what is a need, and how best should we meet that need from a depersonalized perspective. So thinking about well-being from an objective perspective. And then they say, okay, you need to go do these things to someone else who is the care provider. In Toronto's theory, she talks about how it's really important to understand how the care is received. So you don't actually know if you've met the need until you've seen how the person responds to that meeting of the need. And so I think the caregiver and care receiver interaction is where the possibility for second personal caring comes in. So if you are not even going to meet the patient, then the only thing you have to rely on is some kind of third personal idea of objective well-being. If you're actually giving the care and seeing how that's responded to, then that's where we have the capacity to have a second personal engagement. So I think that what needs to happen is there needs to be more shared decision making, so that the people who are receiving the care and the people who are providing the care have some input into the way the care is organized and structured. And this has to be good for the caregiver as well. It's not just about the care receiver. It has to be a livable kind of work for the caregiver.
Okay. Okay. So
Now,
yeah, please go on. Please.
I also wanted to say, throughout the pandemic, there have also been, I think, really excellent and almost heart-wrenching examples of healthcare professionals respecting patients in this sort of second personal way that goes beyond just respecting their decisions. And one of the images that really struck me in this kind of way was you saw doctors and nurses working in the hospital wearing full PPE, and they put a picture on their chest, right? And so that's a recognition of the patient's subjective experience, that the patient is going to feel fear, that everyone around them is going to look unfamiliar and frightening. And so that was a very small step that they took that I thought was a recognition of humanity and personhood. So it might not always require changing big, huge institutional structures, but I do think that changing institutional structures would help.
Okay. Okay. So in the end, could you tell me a little bit about your latest book, the volume that recently came out, titled "The Ethics of the Pandemic"? What was your hope for the volume? It was especially exciting to see the case studies and the questions for reflection. So, how do you figure the text sort of featuring in the philosophical literature on the pandemic?
Yes, thank you very much. So the edited collection I put out called The Ethics of Pandemics with Broadview Press is intended to be a textbook. And so that's why there are the discussion questions and the case studies and so forth. And we thought it would be probably interesting for people to teach about pandemics while we're in the midst of one and while people are interested in the kinds of ethical issues that arose. So we tried to make it fairly accessible in price and fairly short, because we were thinking that some professors might not want to do a whole class on the ethics of pandemics. They might want to just do a unit. And so by trying to keep the price down, it's $20 Canadian, I think. Pardon?
I think that's great. I think that's great. Coming from a global South country, I think that's a great price.
Yeah. One of the limitations of the book actually is that it does focus a little bit on North America. And this is because we weren't sure whether we would get international rights when we first started the book, but I believe they did secure international rights. So one of the things that I've done to try to remedy that is we have a companion website. And so I'm adding additional articles on the companion website, and that's where you find sort of more non-Western perspectives on the pandemic. I wish I could have put it in the book, but like I said, there's a lot of limitations.
Okay, that sounds great. Could you share the link with me later for the companion website? Maybe I could share it with my students and they could see.
Sure. Yeah.
Mm-hmm. That'd be great. Okay, so that's all the questions I had, Meredith, and thank you so much for being so patient, for joining me today, for taking out the time. And,
well, thank you for having me, and thank you for reading my work. I really appreciate it, and it's nice to get to share these ideas.
Thank you.